I'm Michelle Kittleson, heart failure transplant cardiologist at Cedars-Sinai in Los Angeles, California. We're joined by Dr. Yuk Law. Dr. Law is director of the Cardiac Transplant and Heart Failure Service at Seattle Children's Hospital and professor in the Department of Pediatrics at the University of Washington School of Medicine. So let's move on now to diagnosis. Tell us about the diagnosis of myocarditis in children. What presentation should alert clinicians to the possibility?
It's very tough in children in particular because kids get infected all the time. A lot of our encounters in the emergency room, admissions to the inpatient team is infection, not heart attacks, not strokes, atrial fibrillation, stuff the adult world sees in the emergency room. And the trick is always how to differentiate the real inpatient admission from something else that may be hidden. And so what I would say is that if a presentation seems different to a frontline provider, and the frontline provider can be pediatric cardiologist, it's not always a adult trained emergency room physician or family practitioner or pediatrician. If it seems somewhat different, particularly when it involves vital signs, heart rate a little too fast for an infection, the blood pressure a little too low, perfusion not too good, I think it's the possibility of myocarditis or cardiac disease, cardiomyopathy should come to mind. And I think we like to rely on our clinical acumen, physical exam, history taking, but I think there is a role for doing frontline biomarker testing, such as a B-type natriuretic peptide and a troponin. I think these tests are so commonly used now, so common as point of care in emergency rooms, even in doctors' offices, that I don't think it detracts our ability to use our clinical acumen to at least get an idea. What is the likelihood that there's something else going on here?
I think that's a great point. In the adult world, we talk about how there's so many non-specific false positives from a troponin or BNP, but I imagine in kids, that's not the case. You're not going to have a kid with a benign cause of an elevation of troponin or BNP.
I'm glad you brought that up in the troponin. A lot of the laboratory reference values, they'll give a certain cutoff, whether it's troponin I or T, they'll give a cutoff, but that's for ruling out MI or acute coronary syndrome. And so at our hospital, we've convinced our lab to scrap that, including BNP too, scrap it and use healthy normal values, meaning a much lower cutoff to raise some suspicion. And even if it's false positive, so-called false positive, it's okay. Sometimes you just have to do a few more echoes, get a few more cardiologists come in the middle of the night to make sure that you're not sending someone home or missing something that is cardiac related.